Xin một tràng pháo tay và excuse me. I would like to introduce some chairman here, and we start the session this morning. Okay. Báo cáo đầu tiên tôi xin trân trọng giới thiệu và kính mời giáo sư Mina Komuta từ Nhật Bản sẽ nói về ung thư gan nguyên phát, đa dạng khối u và những cạm bẫy trong chẩn đoán. I would like to introduce and invite Professor Mina Komuta from Japan, which will talk about the primary liver cancer tumor, heterogeneity and its diagnostic pitfalls. Please. Okay. Congratulations. Okay, this way.
Yes. Hello, good morning. Yes. My name is Mina Komuta from International University of Health and Welfare, School of Medicine, Chiba, Japan. First of all, I would like to thank the organizers to giving me such a wonderful opportunities. And I'm so excited to be here and to meet all of you today to discuss tumor heterogeneity of primary liver cancers and its clinical relevances. There is something. So, the primary liver cancers mainly composed by three different subtypes, namely hepatocellular carcinoma, intrahepatic cholangiocarcinoma, and combined HCC and CCA. And as you know that intrahepatic cholangiocarcinoma is the most aggressive phenotype compared to the other two subtypes. And so the distinction of these tumors is very important. However, do you know that when even the tumors, when the similar size of tumor subtype can behave differently after treatment? And I can show you the example. Okay, so here, everything is new, so here you see the two patients presenting the same tumor size, 225 millimeters, and the HCC developed in the same etiology, hepatitis C virus, chronic hepatitis. And we treated successfully of these lesions, and after following CT presented no sign of residual tumor, as you can see here. However, 6 months later, the outcome was completely different between these two patients. So, the first patient present still better prognosis, and they didn't show, the first patient did not show any sign of recurrence, but the second patient presented already the tumor recurrence with portal vein thrombosis, as you can see here. And this can tell you that the treatment efficacy is different even in a similarly sized HCC. And this indicates that tumor heterogeneity does exist even among same size HCC patients. And also, we have to consider the tumor heterogeneity among different subtypes of primary liver cancers. Clinically, it's very important to distinguish between HCC and non-HCC, which means combined HCC and CCA and intrahepatic cholangiocarcinoma, because treatment strategy is totally different between HCC and non-HCC. For example, liver transplantation is mainly for patients with HCC, but not for combined HCC and intrahepatic cholangiocarcinoma. That's why we have to make sure to distinguish either HCC or non-HCC. However, this distinction is not always straightforward as you may think. That is because of tumor heterogeneity and histological continuity that these tumors present, especially poorly differentiated HCC, combined HCC and CCA, and intrahepatic cholangiocarcinoma small type present heterogeneity and histological continuity, which makes it quite challenging for us to distinguish these tumor subtypes. And that is probably secondary due to the fact of the different cell origin. So, based on this aspect, today my presentation will be focusing on tumor heterogeneity of primary liver cancers, following these aspects. So let's start with hepatocellular carcinoma. Firstly, I would like to explain the importance of the correlation between macro and micro features. So the tumor differentiation is a fundamental subject that when we are dealing with carcinoma. So when we diagnose carcinoma, we always mention the tumor differentiation. A tumor differentiation is assessed by the factor that how tumors will preserve the nature of its cellular origin. So when it comes to hepatocellular carcinoma, we have to see that how tumor can still preserve the nature of hepatocyte. So when you look at the well-differentiated HCC and moderate and poorly differentiated HCC, you can see the difference in terms of color and also structure. So well-differentiated HCC still preserve the thin trabecular growth pattern, looks like a hepatic plate, and also tumor color looks like eosinophilic, which also preserving the nature of hepatocyte. However, when tumor becomes poorly differentiated HCC, the tumor cell becomes more basophilic and the structure becomes more solid. So they lose the feature of hepatocyte. The important distinction in clinics is to see the difference between well-differentiated HCC or moderate or poorly differentiated HCC. Because well-differentiated HCC does not present vascular invasion. However, moderate or poorly differentiated HCC do present vascular invasion, which means that tumor is more aggressive and tumor can metastasize easily. That's why when we make a diagnosis of HCC, we have to make sure that this tumor is well differentiated or moderate or poorly differentiated. So that distinction is crucial. And this tumor differentiation has strong correlation with macroscopic aspect. Here you see that. So that you see the simple nodular aspect in the middle, and then you see the tumor present somehow green color. You know that hepatocyte can produce bile. That's why well-differentiated HCC can still produce bile. That's why the well-differentiated HCC often present green color in a macroscopic aspect. And this is often seen in the context of simple nodular type. And usually this macroscopic type is seen in a less than 2 centimeter tumor and no sign of vascular invasion. However, when tumor presents simple nodular type with extra nodular growth pattern, as you can see here, then extra nodular growth pattern indicates the presence of vascular invasion, and the color is becoming more whitish, less green color, and the tumor differentiation is usually moderate. And we see vascular invasion more often, and the tumor size is usually around 4 to 5 centimeters. And then, this is the worst macroscopic presentation, namely confluence multinodular type. And this macroscopic type is a kind of aggregation of vascular invasion. That's why you see small tumor clusters collecting this the macro aspect. And this tumor is mainly composed by poorly differentiated HCC, and it's a highly aggressive macro aspect. And this type of patient often present intrahepatic metastasis or even extrahepatic metastasis. So there is a strong correlation between macroscopic features, tumor size, tumor differentiation, and vascular invasion, as you can see here. And this can tell you that we can somehow expect tumor aggressiveness based on the tumor size, which means that if tumor is larger than 5 centimeters, you may expect that this tumor can be very aggressive with the vascular invasion. However, I have to mention that this correlation is mainly seen in the context of viral hepatitis B or C, but not in steatohepatitis context or other contexts. That I'm going to explain now. So the etiology and tumor feature are important. So nowadays, in America, Europe, and also in Japan, actually more than 60% of HCC arising from non-viral liver condition. And the main cause of non-viral HCC is either elderly patient or steatohepatitis that I'm going to explain later. So the HCC arising in elderly patients, which is usually older than 75 or 80 years old, this HCC has a peculiar aspect, meaning that usually it's female predominant, and it could be a quite large tumor. It's often more than 5 centimeters in diameter. However, when you look at the macro aspect, it shows green color, meaning that cancer can still produce bile, which means that the tumor is well differentiated. And also, it doesn't show any vascular invasion. So, which means that it doesn't, so larger tumor size is aggressive. This theory does not work in the HCC arising from elderly patients. A similar feature can be also seen in the context of steatotic liver disease-related HCC. So in fact, nearly 50 or 60% of steatotic liver disease-related HCC occurs in non-cirrhotic condition. And this type of tumor also presents solitary at a larger tumor size, but less vascular invasion, and tumor is usually well differentiated. So this type of tumor is good for the curative operation. This operation is a good indication for this type of tumor, because after curative operation, patient can expect a good prognosis. However, when tumor arrives in the context of liver cirrhosis, it behaves more like a similar aspect like a viral-related HCC. And more importantly, this type of tumor often presents steatohepatitis pattern, as you can see here, characterized by the presence of steatosis, lymphocytic inflammation, and ballooned tumor cells. So the HCC in metabolic syndrome or elderly patients show different clinical presentation, which means that larger tumor does not mean that tumor is malignant. And also we have to pay attention that those tumors arising from normal liver, which means that we have to pay attention to distinguish between HCC and focal nodular hyperplasia or hepatocellular adenoma or even metastatic tumor. because these tumors present hypervascular lesion, and also these tumors often occur in a normal liver. So now I'm going to show the example of focal nodular hyperplasia and hepatocellular adenoma. So the focal nodular hyperplasia is a benign hepatic lesion, benign hepatic hyperplastic lesion, which often present fibrotic scar in the center of tumor. And the glutamine synthetase present map-like pattern, as you can see here. In contrast, hepatocellular adenoma present a single mass without fibrous capsule, and usually glutamine synthetase shows a diffuse expression, as you can see here. And FNH is a 100% benign lesion, and hepatocellular adenoma has a potential to become malignant. So it's important to distinguish these tumors from hepatocellular carcinoma. And also, I really would like to draw your attention that neuroendocrine tumor can really mimic hepatocellular carcinoma, as you can see here. This is a tumor biopsy. Actually, the patient from metastatic neuroendocrine tumor in the liver, and it looks like ACC, but when you look at carefully, you can see somehow this cohesive aspect of these tumor cells. And synaptophysing and the neuroendocrine marker shows diffusely strong positive in this tumor. So when you have some strange feeling of the tumor aspect mimicking ACC, my suggestion is to perform neuroendocrine marker to exclude the possibility of neuroendocrine tumor, because neuroendocrine tumor is often metastasized to the liver, and it can be single lesion and it can be multiple lesions, and it presents hypervascular lesion like hepatocellular carcinoma. So now then, we are moving on to the aggressive phenotype of ACC. So I need to emphasize to all of you that when you make diagnosis of ACC, you know, making a tumor differentiation is not enough to characterize tumor anymore, because we have so many different aspects that can really predict tumor aggressiveness in ACC. And here I would like to present 3 different subtypes which really affect the patient prognosis. Macrothoracic massive subtype and the vessel that encapsulate tumor clusters that we often call VTC. These patterns strongly correspond to lung metastasis. And also keratin-19 positive ACC has a correlation with the risk of lymph node metastasis. The macrothoracic massive subtype is characterized by the thick tumor structure, usually composed of more than 10 tumor cell components. And it has a strong correlation with hepatitis B virus infection, and the patient often presents high AFP serum levels. And it has a correlation with lung metastasis. And compared to the macromassive subtype, these vessels that encapsulate tumor clusters pattern, VTC pattern, is diagnosed by using CD34 staining. So you see the tumor clusters surrounded by CD34 positive endothelia, as you can see here. So this tumor subtype is diagnosed by using immunohistochemistry. Consequently, it has a less inter-observer discrepancy among pathologists when it comes to the diagnosis of VTC pattern. And it has a strong correlation of lung metastasis. And then keratin-19 positive ACC. So this tumor is usually present just normal hepatocellular carcinoma based on hematoxylin eosin staining. But when you perform keratin-19 immunohistochemistry, you can see somehow the weak membranous positivity in the tumor cells. And if you see this heterogeneity expression in more than 5% of tumor cells, we can diagnose it as heterogeneity positive HCC. And it has a correlation with lymph node metastasis risk. And compared to the heterogeneity negative HCC, the tumor outcome after operation is worse. So it's a poor prognosis. And the picture that I presented at the beginning of my presentation, in fact, the second patient who presented recurrence after 6 months of treatment, the patient was actually presenting heterogeneity positive HCC, and the first patient was heterogeneity negative HCC. So this can tell you that how heterogeneity positive HCC behaves aggressively. And also, this is very important point, that these highly malignant aggressive phenotype of HCC often present non-typical HCC imaging, as you can see here. So usually, hepatocellular carcinoma shows hypervascular lesion in arterial phase and washout in the portal phase. But as you can see here in the picture named B, you see only link enhancement in the arterial phase. That's what we call as non-typical HCC imaging by the definition of radiology. And this link enhancement is usually indicate the possibility of intrahepatic cholangiocarcinoma or metastatic tumor, but in fact, this imaging pattern is also a picture of macroclavicular massive subtype or heterogeneity positive HCC. So this can tell you that imaging is not perfect, and that to make the diagnosis accurately, we have to really collaborate with radiologists to make a better diagnosis. So now we are moving on to the intrahepatic cholangiocarcinoma section. So, as you know that intrahepatic cholangiocarcinoma has been increasing across the world, and it's a highly malignant tumor, which is only 15 to 40% of 5 years of overall survival, even after curative resection. And it often diagnosed as an advanced stage, and chemotherapy is not really effective for intrahepatic cholangiocarcinoma. However, the treatment strategy has changed drastically recently because of the achievement of molecular diagnosis. So the fifth WHO classification, published in 2019, introduced new subclassification of intrahepatic cholangiocarcinoma. So now we know that intrahepatic cholangiocarcinoma is a heterogeneous tumor comprising two different subtypes, namely large duct type and small duct type. And this diagnosis is purely based on the morphological subclassification. However, it has a strong correlation in terms of clinical aspect, histological aspect, and also molecular aspect. That's why this subclassification has received a great attention, and now we are working on the 6th WHO classification at this moment, and this subtype will become an independent chapter in the 6th WHO classification, which will be published, I think, at the end of the next year. And why it's so important? Because the actionable mutations, namely IDH mutation or FGFR2 fusions, are mainly seen only in the small duct type, but not in the large duct type. And I'm going to explain why this difference can happen. So, the cholangiocarcinoma originates from cholangiocyte lining of the bile duct. But the cholangiocyte phenotype is different depending on the size of the bile duct. When you look at the small bile duct, the cholangiocyte presents small, cuboidal, and mucin-negative features. In contrast, the large bile duct is lined with mucin-producing cylindrical cholangiocyte, as you can see here. And this different aspect can also be seen. So the different cholangiocyte phenotype can also be seen by using immunohistochemistry, as you can see here. So the small bile duct is usually shown positive by CD56, but negative for S100P, and EMA shows apical staining pattern. In contrast, large bile duct shows CD56 negative and S100P positive, and EMA shows strongly positive. So, if the cholangiocyte phenotype is so different, it's quite understandable that cancer phenotype is also different. So that when small bile duct present cancer, the cancer presents mucin negative and irregularly structured ductular proliferation, as you can see here. And when large bile duct present cancer, the tumor can be mucin producing and clear glandular structure, as you can see here. And now we are going to more detail in terms of large duct type ICCA. So the large duct type cholangiocarcinoma is originating from the large bile duct. So the tumor infiltrates into the Wilson portal tract, as you can see here. And it shows a thickening of the portal tract, as you see. And as a consequence, the peripheral bile duct gets dilated. And this can be also seen by imaging, as you can see here. So here the stenosis, and then dilatation of the intrahepatic bile duct. But the cancer also invaded into the neighboring parenchyma and making a mass, as you can see here. And the histological aspect shows mucin-producing glandular structure, as you can see here. This aspect is quite similar to that of the large bile duct. And I would like to emphasize that this pathological aspect is quite similar between perihilar and distal cholangiocarcinoma and even pancreatic cancer, because intrahepatic bile duct and extrahepatic bile duct and also pancreatic duct are lined by similar cylindrical mucin-producing epithelial cells. And also they share the same embryogenesis. That's why when they make a cancer, the cancer pathology looks quite similar. And this is a kind of summary of large duct type ICCA. So the cancer is developing from the large bile duct. So the tumor location is usually proximal to hepatic hilar area. And then as a risk factor, the chronic viral inflammation such as primary sclerosing cholangitis or hepatolithiasis or liver fluke infection are known as a risk factor for the large duct type ICCA. And this cancer is developing from the chronic continuous inflammatory condition of the bile duct. We often see the precursor lesion, the biliary intraepithelial neoplasia or intraductal capillary neoplasm of this large duct type ICCA. And this tumor is a highly aggressive phenotype, often presenting perineural invasion and lymphatic invasion. And most importantly, the molecular feature is quite similar with that of pancreatic cancer or extrahepatic bile duct cancer, showing the KRAS mutation and SMART4 loss in this type of cancer. However, the tumor aspect and clinical presentation are totally different in small duct type ICCA. First of all, the macroscopic aspect. The all small duct type ICCA shows mass-forming type, as you can see here, mass-forming type. And the tumor structure shows more heterogeneity. It can be a ductular reaction-like aspect, or it could be a small uniform tubular structure, as you can see here. So it's more diverse histological aspect seen in a small duct type ICCA. And when you look at closely the tumor cells, the tumor cell looks like, we often call it as an innocent looking, because the cellular atypia is not that severe. And the mucin production is not recognized in this type of tumor cells. And the EMS staining shows nicely apical staining pattern, whereas large duct type ICCA shows cytoplasmic EMS staining. And the small duct type ICCA often associated with chronic hepatitis, as you can see here. So this is the summary of small duct type ICCA. The location of the tumor is usually peripheral because it's originating from the small bile duct. However, 30% of small duct type ICCA can occur in the perihilar area because bile duct shows a three-dimensional aspect, and a small bile duct can also exist in the perihilar location. And as a risk factor, the chronic viral hepatitis or metabolic syndrome are known as a risk factor for small duct type ICCA. And the precursor lesion is not known in this type of tumor, and more importantly, the actionable mutations such as IDH1 mutations and FGFR2 fusions are mainly seen only in the small duct type ICCA. And the prognosis is also different. The small duct type shows better prognosis compared to the large duct type after operation, as you can see here. And when you look at the molecular aspect, the molecular feature is completely different between small duct type ICCA and large duct type ICCA and perihilar and distal cholangiocarcinoma. In fact, the intrahepatic cholangiocarcinoma, large duct type, and perihilar and distal cholangiocarcinoma, and also pancreatic cancer share the similar molecular profile, same as histological aspect. But the intrahepatic cholangiocarcinoma small duct type is completely different in terms of tumor structure and also molecular features, which means that intrahepatic cholangiocarcinoma should be distinguished between small and large duct type ICCA. So now we are moving on to the metastatic tumor. Here, this is a picture of tumor infiltrating, the tumor cell infiltrating in the liver sinusoid. And it looks like intrahepatic cholangiocarcinoma small duct type, but actually this tumor was originally from breast cancer. So the breast cancer metastasis, especially invasive lobular carcinoma, mimics the feature with like a small duct type ICCA. So the distinction is very important, either primary or metastasis. And here, this was taken, this liver biopsy was taken in the context of intrahepatic cholangiocarcinoma suspect. But we had a feeling that this morphology is not consistent with intrahepatic cholangiocarcinoma, so we performed immunohistochemistry showing that CDX2 was diffusely positive, as you can see here. So we suggested clinician to perform colonoscopy, and consequently they found colon cancer, which presents quite similar morphological aspect. So when it comes to when you see the adenocarcinoma in the liver, firstly, you have to pay attention that this tumor can be primary or secondary, because the distinction between primary or secondary tumor is essential because treatment strategy is totally different. And so that we need to use immunohistochemistry. We need to immunohistochemistry in order to distinguish between primary or secondary tumor. However, the recent paper presented that in fact 34% of unknown primary origin adenocarcinoma were in fact intrahepatic cholangiocarcinoma. So the diagnosis of intrahepatic cholangiocarcinoma is still challenging. So now we are moving on to the combined HCC and CCA. So the combined HCC and CCA is a tumor comprising of two different aspects, HCC and cholangiocarcinoma. And these two different features show transitional aspect. And when you look at the macroscopic aspect of combined HCC and CCA, you can see the different color. Here you see more grayish, yellowish color corresponding to HCC areas, but in the middle you see the whitish fibrotic area corresponding to the adenocarcinoma areas. And when you look at when we compare the immunohistochemistry and histology, you see that the whitish area is positive for keratin-19, the biliary marker, and this yellowish area is positive for HEPA1, which corresponds to hepatocellular carcinoma areas. And the histology shows nicely present the difference between HCC and cholangiocarcinoma component. That there is a diagnostic problem in combined HCC and CCA because there is no, in fact, all cases has a unique proportion of each component, which means that some combined HCC and CCA shows 90% of HCC aspect and 10% of cholangiocarcinomas, but the other cases might be composed by 90% of cholangiocarcinoma and 10% of HCC. And this can be problematic when it comes to the imaging diagnosis, as you can see here. So, if combined HCC and CCA predominantly composed by HCC component, the imaging aspect shows more hypervascular tumor, mimicking like HCC aspect. But if combined HCC and CCA is predominantly composed by cholangiocarcinoma aspect, it shows no hypervascular aspect, resembling like a metastatic tumor or cholangiocarcinoma aspect. So the imaging is not really perfect in terms of combined HCC and CCA imaging the diagnosis. But pathology is also a bit problematic because we often see this type of tumor showing that the hepatocytic-like tumor cell presenting a solid growth pattern or even granular structure associating with fibrosis. So we cannot really see that this tumor can be more hepatocytic or cholangiocytic differentiation. So in that case, we need to use some staining and immunohistochemistry to confirm cholangiocytic differentiation. For this purpose, we often use mucin staining, Alcian blue, to confirm presence of mucin because hepatocellular carcinoma does not present mucin. And also we confirm cholangiocytic differentiation by using keratin-19 immunohistochemistry. But the problem is to identify the hepatocytic differentiation because the sensitivity of this immunohistochemistry is different depending on the type of tumor and also the type of combined HCC and CCA. So it's always important to perform at least 2 or 3 different hepatocytic markers to confirm hepatocytic differentiation. So this is my final slide. So when it comes to the primary liver cancers, it's important to understand that primary liver cancers comprise the spectrum. So the spectrum is made by the well-differentiated HCC, which is a kind of representative picture of hepatocyte. And then also the large duct-type ICCA, that's also the representative aspect of the bile duct. However, in the middle, the poorly differentiated HCC, combined HCC and CCA, and small duct-type ICCA shows histological diversity and continuity. And imaging also reflects this heterogeneity of the pathology. That's why there is no specific imaging aspect of each tumor subtype. However, the treatment is different depending on the type of tumor. That's why it's very important to diagnose the tumor by using imaging, pathological feature, and also clinical aspect. Because diagnosis is already a part of the treatment. So, thank you so much for your attention. Thank you.
Thank you very much, Professor Mina Komuta from Japan, with your very interesting presentation today about the liver cancer, liver primary cancer. I think liver cancer is one of the most cancer disease in Vietnamese patient. So maybe there are some questions for you, but we will back to the end of this session to discuss more. Thank you very much again.